ABC Farma, Artificial Intelligence Doctor. Understanding pacemaker-related discomfort patient question. Why does a patient with an Aveir VR LP wake up in the middle of the night with significant discomfort that goes away when standing up? The discomfort returns when lying down in the left lateral decubitus position and then disappears when lying down in the right lateral decubitus position. Analysis and
pacemaker,
explanation.
and no larger than a vitamin capsule, placed directly in the heart. No leads, no surgical pocket. With a simple catheter procedure, it delivers wireless pacing and the freedom to live.
Stimulation. The short answer. The patient is experiencing inadvertent stimulation of their diaphragm by the pacemaker. The left-sided lead of the Aveir VR LP is positioned very close to the phrenic nerve. When the pacemaker delivers an electrical impulse to pace the ventricle, it also captures the nerve, causing the left diaphragm to contract forcefully. This feels like a sudden, uncomfortable, hiccup-like jolt or fluttering in the abdomen or chest. The change in position alters the anatomical relationship between the lead and the nerve, turning this stimulation on and off. The detailed explanation 1. The anatomy, lead and nerve proximity. The Aveir VR leadless pacemaker LP. This device is implanted directly into the right ventricle of the heart. It doesn't have leads running through veins. It's a single unit attached to the heart wall, the phrenic nerve. This nerve runs very close to the surface of the heart, specifically near the right ventricle and the pericardium, the sac around the heart. Its job is to control the diaphragm, the main muscle for breathing. Stimulating it causes the diaphragm to contract. The tip of the Aveir VR LP is positioned in the right ventricle. If the implantation site is on the lateral or posterior wall of the ventricle, it can be in very close proximity to the left phrenic nerve, which innervates the left side of the diaphragm. 2. The mechanism. Why it happens in certain positions. This is the key to understanding the patient's symptoms. Lying down, especially left lateral decubitus. When the patient lies on their left side, gravity causes the heart to shift slightly within the chest, bringing the pacemaker lead closer to the phrenic nerve. This reduced distance means the electrical current from a pacing pulse can now capture both the heart muscle and the phrenic nerve. Result: with every paced beat, the patient gets a strong, involuntary, and uncomfortable contraction of the left diaphragm. It can feel like a jolt, a flutter, or a pounding in the upper abdomen or lower chest. Lying on right side, or standing up. When the patient lies on their right side or stands up, gravity pulls the heart away from the phrenic nerve, increasing the distance between the lead and the nerve. The electrical current is now only strong enough to capture the heart muscle, but not the nerve. Result: the diaphragmatic stimulation stops, and the discomfort disappears. 3. Why it happens in the middle of the night, quiet environment. At night, there are fewer distractions, making the patient more aware of internal bodily sensations, lower intrinsic heart rate. During sleep, the patient's natural sinus heart rate is lower. This means the pacemaker is more likely to be actively pacing to maintain the minimum set rate, e.g., 60 beats per minute, creating more opportunities for phrenic nerve stimulation to occur. Position: people move in their sleep and may roll into the triggering position, left side. What needs to be done? This is not a normal or acceptable side effect and must be addressed. The patient should contact their cardiologist or electrophysiologist immediately. They should not just live with it. The doctor has several options to resolve this. Non-invasive reprogramming, most common first step. This is the preferred initial solution. The doctor can connect the patient to the pacemaker programmer and reduce the pacing output, voltage/pulse, with they will find the lowest energy level that still reliably paces the heart, capture threshold, and then set the output to a safe level just above that. By using less energy, they can often avoid stimulating the phrenic nerve while still pacing the heart effectively. Change the pacing vector. If the device allows, some leadless pacemakers can change the direction of the electrical current. Switching the vector can sometimes stimulate the heart without affecting the nearby nerve. Device repositioning. If reprogramming fails, if the phrenic nerve stimulation cannot be resolved with reprogramming without compromising the safety of cardiac pacing, the doctor may need to perform a second procedure to move the pacemaker to a different location within the right ventricle, typically to a spot farther away from the phrenic nerve, like the septum, the wall dividing the left and right. Ventricles. Summary. In essence, the patient is describing a textbook case of positional phrenic nerve stimulation. The leadless pacemaker is too close to the nerve that controls the diaphragm. Lying on the left side brings them into contact, causing uncomfortable jolts with each paced heartbeat. Changing position separates them, providing relief. This requires prompt medical evaluation to find a solution, usually starting with a simple reprogramming of the device.